Hello all, and thank you so much for attending week one of BFSG's three-part 2021 fall webinar series. This week discussing a really common item many people will face during retirement, either within you or your loved ones, and that is Alzheimer's. We're really pleased to have our guest speaker for today.
Hello, greetings. Thanks for joining this webinar. I want to thank BFSG and Chad and Paul for the opportunity to speak to you all today. My name is Josh Grill. I'm a professor of psychiatry and human behavior, as well as neurobiology and behavior at the University of California at Irvine. I'm also the director of something called the Institute for Memory Impairments and Neurological Disorders, or UCI Mind. We are one of just about 30 and growing, thankfully, up to about 36, I think, NIH-funded Alzheimer's disease research centers in the United States. We're extremely proud to be a part of that network. We're extremely proud of the work that we do here at UCI Mind. UCI Mind is a transdisciplinary organization with more than 50 faculty members and more than 150 investigators who have all devoted their professional lives to studying Alzheimer's disease and related disorders. So we really exist for the express purpose of conducting research and trying to make discoveries that'll help find solutions for these age-related diseases. I refer to us often as a research and education organization. I would say we probably spend 90% of our time, if not more, doing research, but we do recognize the critical importance of sharing with the community at large what we are learning, sharing with people what they can do in their own lives, assuring the public that we are indeed making progress on this really important topic, and making a plea for people to join us in our efforts. So what I thought I would do today is spend 15 or 20 minutes answering the questions that we get pretty much every time we go out in public and talk about Alzheimer's disease. And then I will assuredly devote the majority of our time to taking the questions, some of which I already see popping up in the Q&A, which is fantastic, and some of which I was planning to answer before we even opened up to the Q&A part. So once again, thanks for being here today, and thanks to the organizers for the opportunity to talk. So I am an Alzheimer's disease researcher. This is what I do. This is the entirety of my career. I think it's a really key, important problem. I often refer to it as the most important medical problem we face as a society today. Now, I've been saying that since COVID-19, and COVID-19 is a pretty big deal, and it's actually lowered Alzheimer's disease in the top 10 causes of death temporarily. But COVID-19, I believe and hope, will someday soon be more or less in our rearview mirror. And I'll tell you that Alzheimer's disease is going to keep growing in its impact. So oftentimes I begin these lectures with the single most common question that we get when we give talks, and that is, what's the difference between Alzheimer's and dementia? Dementia is a syndrome, or what I often refer to as an umbrella terminology. It means that someone has cognitive problems with the way they think, and that those thinking problems are getting in the way of living life, or what we might refer to as function, or even activities of daily living. A person meets criteria for dementia when their thinking isn't what it used to be, and that's impacting the way they live. Now, under the umbrella of dementia, there are many different potential causes, and we're happy when someone has dementia that can be treated. I shouldn't say we're happy, but it's better than the alternative when someone has a dementia that can be treated. Maybe they're taking too many medications. Maybe they're severely dehydrated or malnutritioned. Maybe there are hormone changes that are amenable to treatment. Unfortunately, only about 15% of people with dementia suffer from one of these treatable, or sometimes referred to as reversible, causes of dementia. The overwhelming majority of people who suffer from dementia suffer from a neurodegenerative disease, a brain disease, a disease of the central nervous system. And among the diseases that can cause dementia, Alzheimer's disease is overwhelmingly the most common cause of dementia. It's estimated that some 70% of people who suffer from dementia suffer from Alzheimer's disease. So what is Alzheimer's disease? It's the changes that are occurring in the brain that are leading to those cognitive problems and that functional impairment. Specifically, it's accumulation of abnormal proteins in the brain in what we call plaques and tangles. And indeed, some of the questions in the chat were about those plaques and tangles, or to be more specific, amyloid plaques or neuritic plaques, meaning that those are accumulations of a protein called beta amyloid, and neurofibrillary tangles, or what are sometimes referred to as tau tangles. And this is an overprocessed protein that exists inside of brain cells. It's a constitutive part of every brain cell. Every brain cell has this protein tau. But in this case, the tau is being overprocessed, a process we call hyperphosphorylation. So those plaques and tangles are the hallmark changes in the brain that tell us that a person suffers from Alzheimer's disease. Another question that we often get relates to those neurofibrillary tangles and those amyloid plaques specifically. And it is it true that the diagnosis of Alzheimer's disease can only be made after a person passes away? The reason that question is asked is that it, in fact, until recently was quite true that the definitive diagnosis of Alzheimer's disease was only made when we confirmed that those plaques and tangles were present, and we could only do that when examining brain tissue under the microscope. And obviously that was only performed after a person passed away at autopsy. So technically, based on our own diagnostic criteria as a field, it's still true that to make the definitive diagnosis of Alzheimer's disease, we have to confirm that those plaques and tangles are present. And that's done at autopsy. However, the field of Alzheimer's disease research has come extremely far in a relatively short period of time. And we now have tools that can show us if the plaques and tangles are present in the brain while a person is still alive. And there are a handful of different ways we can do that, but perhaps the most powerful is to examine the brain with a form of brain imaging or brain scans, and one particular type of brain scan called a positron emission tomography scan, or a PET scan. A PET scan is a picture taken of the brain after injecting a drug that works as a tracer or a dye. And there are now actually FDA-approved ligands, tracers, that can show us both the plaques and the tangles. And so with these FDA-approved diagnostic tools, we can confirm that plaques and tangles are both present in the brain. And I think it's only a matter of time until we change those guidelines and say that we can make a definitive diagnosis that Alzheimer's disease is occurring in the brain, and that a person who suffers from dementia actually has Alzheimer's disease as the cause of that dementia. So really exciting progress made in understanding how to make this diagnosis. Now, the scans themselves are not a replacement for an expert clinical workup of a person who suffers from cognitive problems and dementia. They are a tool to aid in that diagnosis. So it's not like you can just go get your scan and have your diagnosis. You still need to see an expert diagnostician. This is typically going to be a neurologist, a geriatric psychiatrist, a geriatrician, although certainly in some cases, primary care doctors are well skilled and can make the diagnosis of Alzheimer's disease and dementia in their practices as well. These scans and other tools like them have also helped us accelerate our research. And this has included research into diagnosis and research into treatment. And in fact, we are certainly now getting a lot of questions about drugs, and in particular, the fact that in June of 2021, for the first time in more than 15 years, the FDA approved a new drug for the treatment of Alzheimer's disease. So before that, the FDA had approved 5 different treatments. They were all approved for people with dementia caused by Alzheimer's disease. They existed in 2 classes of medications, what we call acetylcholinesterase inhibitors, which includes drugs like Aricept, Exelon, and Razidine, and a separate class with only one agent in it called Namenda or memantine. All of these drugs are what we would refer to as symptomatic drugs. When patients take them, and most patients with Alzheimer's disease do take these drugs at some point or another, they perform a little better on memory tasks and other cognitive tasks than they would if they weren't taking those drugs. But the drugs didn't slow the course of Alzheimer's disease. They don't slow the course of Alzheimer's disease. So there's been tremendous effort, activity, enthusiasm around testing drugs that can directly target those plaques and tangles in hopes of discovering a treatment that can actually slow the progression of Alzheimer's disease and, in our wildest dreams, stop or reverse the course of Alzheimer's disease. The new drug that was approved benefited immensely from the development of those biomarkers, those PET scans that can show us the plaques and the tangles. In fact, the new drug, which is called Aducanemb or Aduhelm, was approved specifically because of its ability to lower plaques in the brain. The drug has been associated with some controversy. Those controversies are numerous and ongoing. They begin with the fact that the clinical trials that were conducted in an effort to demonstrate that the drug could slow the course of Alzheimer's disease were mixed in their results. There were 2 extremely large studies. One suggested a benefit of aducanumab in slowing Alzheimer's disease. The other did not. And ultimately, an FDA advisory panel voted staunchly against approving this drug. And so what ended up happening is that the FDA approved the drug through a unique pathway known as the accelerated approval pathway. And basically, the decision made by the FDA said, we are convinced, and I am as well, that treatment with aducanumab can lower amyloid plaques in the brain. And then the FDA concluded that there's reasonable reason to expect that that would be associated with a clinical benefit. I personally am less convinced about that part, and I think more studies are needed. And indeed, the accelerated approval came with a requirement that the maker of that drug do an additional clinical trial to confirm that the drug is associated with a clinical benefit. We're still waiting to hear about the design of that study. So this was major news, first approval in more than 15 years. There are a variety of other controversies that I can get into if the audience is interested, but the take home here is that we're making progress. A new drug's been approved. There's still work to be done. This drug has not yet been convincingly shown to actually have a clinical benefit for patients with this disease. New studies will be done and are still needed. But other drugs are close behind. In fact, 2 other drugs have begun or been submitted to the FDA for a similar accelerated approval. So there is a lot of excitement around what we're learning. I do want to say that there's a lot of excitement around what we're learning outside of drugs as well. In particular, more than 40 different genes have been identified as playing a role in who does and does not get Alzheimer's disease. And even taking all that we know about those genes, we really can't assess a person's genetics when they're 30 or 40 and say who will and will not someday succumb to Alzheimer's disease later in life. The understanding of that genetics is very important and could reveal new treatment targets that ultimately could, help us figure out a way to prevent everyone from getting Alzheimer's disease. But right now, that's really exciting. It may yield new targets for drugs, but it's also clearly not the whole story. In fact, if we take everything we know about genes, we think we can assess approximately 50% of the risk for getting Alzheimer's disease to be as a result of a person's genes. What's perhaps most important about that is that that leaves 50% of the risk for getting Alzheimer's disease that we can attribute to a person's environment and their lifestyle choices. And here too, there is great enthusiasm, excitement, and activity in the research space about how do we take the information available to us about environment and lifestyle choices and harness that to help people make lifestyle choices that can lower their risk for getting Alzheimer's disease. So it is now clear that 50% of the risk is due to lifestyle choices, and we want people to take this information and make lifestyle choices that lower their own risk for getting Alzheimer's disease. In fact, I have a whole hour-plus long talk called Lowering Your Risk for Alzheimer's Disease. So we know that there are a variety of risk factors for Alzheimer's disease, things that do increase risk for Alzheimer's disease or things that lower our risk for Alzheimer's disease. Overwhelmingly, the strongest risk factor for Alzheimer's disease is age. For every 5 years we live after the age of 65, our risk of getting Alzheimer's disease doubles. So my number one recommendation is always to stop aging today. Stop right now. That's the best thing anyone could do to lower their risk for Alzheimer's disease. Realistically, we also know that there are several other lifestyle risk factors that we can harness in order to try to lower our risk. Those risk factors are numerous. We know that what's good for the heart is good for the brain. So protecting ourselves by monitoring carefully our blood pressure, our cholesterol levels, etc. These things are extremely important to lowering our risk for Alzheimer's disease later in life. Similarly, if we are smokers, we should stop for innumerable reasons. Obviously, smoking is a risk factor for cancer, but it turns out that smoking is a risk factor for dementia as well. And so that may be a cardiovascular pathway or maybe a more direct pathway to what's happening in the brain. No matter what, it really doesn't matter. If you're a smoker, you should stop as soon as possible. There are also positive things we can do to try to improve our brain health. Probably the single greatest thing we can do to improve brain health is to make sure we get adequate amounts of physical exercise, aerobic exercise. This obviously helps control our blood pressure and our cholesterol, increases our cardiovascular health. The main job of the heart, I assure you, is to pump blood to the brain. It's our most vascular organ. It uses 20% of our blood oxygen and our blood sugar, despite only making up about 2% of our total body weight. So the main job of the heart is to make sure that the blood is well resourced with blood oxygen and blood glucose. But exercise has direct effects on the brain as well. It can cause blood flow to the brain. It can cause sprouting of new blood vessels in the brain. It can even lead to the production of what we call neurotrophic factors, proteins made in the brain that are important to brain cell survival and function. So exercise can actually produce those healthy brain proteins. And in certain parts of the brain, we continue to make newborn brain cells throughout life, although the rate at which we make those newborn brain cells seems to go down a bit with age. And physical exercise, aerobic exercise, can increase the number of newborn brain cells, and in older animals can bring those levels back to a youthful level. So physical exercise is really important. We also have reason to believe that we can diet away from dementia. Now, obviously, we want to avoid foods that are high in fat and high in cholesterol that impact our cardiovascular health. But numerous studies suggest that getting enough healthy foods in our diet is also a key to lowering our risk for dementia. So you may have heard about the Mediterranean diet. This is a diet that has consistent levels of fish and other sources of healthy fats like olive oil and mixed nuts. It's high in foods that are high in antioxidants like berries, and it's also high in dark green leafy vegetables, your spinaches and your kales. There are other diets like the DASH diet. This is an anti-hypertensive diet that focuses on getting some of those healthy foods, but also avoiding some of those unhealthy foods. And in no relation to the institute that I'm a part of, UCI Mind, there's something called the Mind diet, developed by colleagues at Rush University and their Alzheimer's Center, that really tries to combine these things. In the end, the most important thing is that you're getting enough seafoods and healthy fish and other healthy forms of fat, avoiding the highly processed carbohydrates and high cholesterol foods, and eating enough fruits and vegetables. And that is indeed a fantastic way to try to lower your own risk for developing dementia. There are some other things that are very interesting, and important work is ongoing. These include things like staying mentally and socially active as we age, and even challenging our brain, if you will, the use it or lose it hypothesis. So making sure that once we reach retirement age, we don't stop using our brain altogether. Challenge yourself, learn a new language, learn a musical instrument, force your brain to actually learn complex tasks. That may ultimately be key to protecting those synapses, protecting those brain cells, and maintaining brain health. And then lastly, and it's somewhat more recently in our field, but I think it'll soon produce a Nobel Prize. We've now identified and understand that when we sleep, we turn on these physiological systems that actually cleanse the brain. So there's physical changes in the brain when we sleep, there's physiological changes in the brain when we sleep. A system was identified that's referred to as the glymphatic system. And it's a way that we remove toxic proteins from the brain. And we do this most while we're sleeping. And many studies have now suggested that the amount of sleep and the quality of sleep we get may be directly tied to our risk for developing dementia later in life. So if we're not able to get, at least 7 hours of sleep, or if we suffer from sleep apnea and other challenges to our sleep, we should really seek out an expert clinician, a sleep medicine doctor, to help us improve our sleep hygiene. There are certain recommendations that I or any other investigator can make. You should limit your activities in bed to sleeping, and maybe one other thing. You should avoid the phones and the tablets in your bed. You're training yourself to be awake while you're in your bed. Avoid nightcaps. Do relaxation techniques before bed. Don't eat your last meal too close to bedtime. Make sure you get your physical activity during the day. It'll help you fall asleep at night. And if all these things don't help you get an adequate amount of sleep, ideally 7 hours, if not 8, then you want to talk to a sleep medicine doc and find a way to improve your sleep, because it's clear that this is absolutely key to protecting brain health. Does all this matter? Does this laundry list of recommendations I've made to you actually work? There's actually really solid evidence to suggest that this does matter, that if we could get people to adhere to these recommendations more, we could actually reduce the total number of cases of Alzheimer's disease. And in fact, in nations like ours, including the United States, United Kingdom, some Scandinavian countries, we have actually seen small, but meaningful reductions in the total number of people per age group who are getting Alzheimer's disease. This is in the order of 1 to 2% reductions in the number of people getting Alzheimer's disease, what we call the incidence of this disease. And mostly we attribute this to higher levels of education available to people, complex jobs, increased understanding of the importance of exercise and diet, and the advent of antihypertensive medications and blood pressure controlling medications. Unfortunately, though we're seeing these very small decreases in incidence, this is going to give way to extremely large increases in prevalence, the number of people at any one point in time who suffer from the disease. And the reason for that is that I told you the #1 risk factor for Alzheimer's disease is older age, and the fastest growing segment of our population is older people, more or less, no matter how you define it. If you define older people as 90 and older, that's the fastest growing segment of our population. If you define it as 70 and older, that's the fastest growing segment of our population. Science and medicine have done a fantastic job of helping people live longer lives. In fact, again, COVID, for the first time in many years, is going to reduce our average lifespan in this and pretty much every other country. But we were doing a great job of increasing longevity globally. But this is going to produce astronomical increases in age-related conditions. So babies born today have a 1 in 2 chance of living to be 100. And the overwhelming majority of people who suffer from Alzheimer's disease are 85 and older. And so, believe it or not, there are 6.2 million Americans living with Alzheimer's disease today. And if we can't find ways to prevent the disease, lower risk for the disease, delay the onset of this disease, that number is going to triple in the next 3 decades or so. And that makes Alzheimer's disease on its own potentially capable of bankrupting the US healthcare system. It's that big a problem, and that's why I refer to it as the most important medical problem we face today. Now, just a couple of other final thoughts before we turn our attention to the Q&A. One, I made a list of recommendations of things you can do in your own lifestyle to try to lower your risk of getting Alzheimer's disease. I'm doing that free of charge. You don't have to send me a check. You shouldn't have to pay for those recommendations. You don't have to buy expensive books. You don't have to go stay in a hotel and participate in a workshop. You don't have to enroll in some sort of program online to get those basic recommendations. Unfortunately, in my field, there's another thing that's happening with some frequency, and we refer to it as pseudo-medicine for dementia. People are prescribing very expensive brain scans, very expensive supplement programs. There's no evidence to support any dietary supplement as a way of preventing Alzheimer's disease or treating it. There are groups who are claiming things like stem cell therapies for Alzheimer's disease. They may or may not call this a clinical trial, but they are then charging thousands of dollars to participate in these programs or in these studies. Research should never be costly for people who want to participate. In fact, we should pay people for their role in making contributions to our efforts to find solutions for these diseases. So please be wary of things that come with high price tags, or frankly, any price tag. We make these recommendations as often as possible, hoping that people will lower their risk for getting Alzheimer's disease. And if there's a big price tag associated with it, it doesn't mean that it's going to be more helpful. Drugs, of course, have price tags. FDA-approved drugs can be very expensive. There's a lot of ongoing conversations about the price of drugs, including the drug that I discussed earlier. And we frankly don't yet know the answers as to whether that drug is going to be covered by Medicare or private insurers. So stay tuned for that as well. Lastly, those scans that I mentioned that can show us the plaques and the tangles in the brain have also produced really key discoveries about when Alzheimer's disease begins. And in fact, if we follow enough people earlier in their older years, for example, in the 50s, 60s, and 70s, we can then, we have learned that the plaques and the tangles begin long before the memory and thinking problems do. Probably 10, if not 20 years before those memory and thinking problems begin, the plaques and the tangles are starting to accumulate. And we are now doing actual clinical trials of drugs that directly target the plaques and the tangles in people who have those those signs of the disease present, but have perfectly normal memories. And I'm part of a very large international study that's ongoing now that aims to ask, if we get rid of the plaques before the memory problems begin, can we delay or prevent the onset of memory problems? That's called the AHEAD study. It's a very novel, very aggressive clinical trial. There's no charge to be in it. In fact, we try to make it cost neutral by paying people for their participation because it's a very involved study. It's a 4-year clinical trial. The drug that we're testing actually has been shown to lower the levels of plaques in the brain. We're only including people who have evidence of the plaques present while they have normal memories. So to be in the study, you have to agree to go have one of those brain scans and learn if you have plaques accumulating in your brain. It's only for people age 55 to 80. It's happening again around the country and indeed in multiple countries. And if you think this might be something of interest to you, if you had a parent with Alzheimer's disease, or if you're concerned about your risk for getting Alzheimer's disease, I would urge you to check out the website for this study at aheadstudy.org. And that's just AHEAD study, STUDY.org. You can learn more about this 4-year clinical trial of a very novel, aggressive treatment that we hope may someday be demonstrated to be able to delay or prevent the onset of Alzheimer's disease. Now, I close all of my public lectures, and I promise I'll move on to the Q&A. I close all of my public lectures by telling people how they can help us. And I usually abbreviate into what I call the 3 8s. Everyone can advocate, donate, and participate. You can advocate by writing to your local, state, and federal representatives to say Alzheimer's disease is a big deal. We need more funding for research. We need more resources for families who are dealing with this disease, because we do on both accounts. You can donate. Organizations like mine certainly do take philanthropic gifts, and they actually help us do science at an accelerated rate. But if you, like our hosts, are here in California, there's also a tax checkoff in your annual tax forms that lets you say, I would like to make a small donation to Alzheimer's research, and that allows for a statewide research competition. So there's multiple ways that you can donate. But far and away, the most important thing people can do is to participate. The single greatest, most consistent barrier to medical advances in any area of medicine is low rates of participation by the public in our studies. So if you're interested in the AHEAD study, I would urge you to check out that website. Here at UC Irvine, we have novel tools we call recruitment registries, where you can sign up, say, I'm willing to hear about studies if anything comes along for which I might be right. And there's really no obligation. It's confidential and it's free. You're just saying, yeah, it's okay with me if you want to let me know about studies that I might be right for. Our local registry is called the Consent to Contact Registry, or C2C, and it's just at c2c.uci.edu. That's C, the letter, 2, the number, and C, the letter. There are a number of other registries that are happening, many of them local, but also many of them national that I'm affiliated with. And there's lots of ways that people can get in line to say, you know what, I'm ready to help if the right opportunity comes along for me. So in closing, I hope that I've convinced you that Alzheimer's disease is a big deal and an important problem. I hope I've convinced you that there's something you can do for yourself to try to make sure you don't have to deal with this problem. And I hope I've convinced you that everyone is in a position to help us by thinking about advocating, donating, or participating. With that, I'm going to ask Chad to unmute and help me get through what looks to be a pretty healthy number of questions in the Q&A.
We have a really good list of questions. There are some duplicates, so I'll try to merge some of the questions together as we go. The first question, which we got a couple times, and I'm going to tie it in with another question that's later, is I think the big one on everybody's mind is Alzheimer's hereditary? And then to kind of give an example to that, because I know it's another question, is say a parent has Alzheimer's and just recently passed away, does that mean that their children are likely to get it as well?
Yeah, it's a really important question. I kind of alluded to it, but I didn't answer it directly. So there is a hereditary component to the risk for getting Alzheimer's disease, but it is not, in 99.9% of the cases, it is not an inherited disease. So if you had a parent who had Alzheimer's disease, you are more at risk than someone who does not have a parent that had Alzheimer's disease, but it is certainly not the case that you are destined to get Alzheimer's disease yourself. And, you know, we have some numbers on this. They're not great, but the estimates are that if you have a parent who had Alzheimer's disease, you may be 50% more at risk than someone who doesn't have a parent with Alzheimer's disease. But if all of our lifetime risk of getting Alzheimer's disease is somewhere in the order of 11%, then that means your risk goes up to something like 16%. This is certainly important. And I did talk about genes. So really, this is probably a mix of the genes you got from your parents and the environment that you both probably live in, and any sort of lifestyle choices that you made in common with your parent. But even twin studies show us that monozygotic twins can be discordant. One can get Alzheimer's disease and the other may not. So it's just simply not as easy as genes dictate. So genes matter, family history matters, but the choices we make matter as well.
So then, and I know you did get through this a little bit too, because I was already taking notes of myself, the Mediterranean diet and all that kind of stuff, and more seafood. So I think what can someone do to prevent Alzheimer's? Like any specific foods, diets? And you're just kind of reiterating it for the audience.
So I can't tell someone an exact recipe to make sure you'll never get Alzheimer's disease. I can't say that with 100% certainty, if you do X, Y, and Z, we will prevent Alzheimer's disease in you. And I should say, no one can do that. And some people are out there saying that they can do that, and it's just not true. No one can tell you if you do X, Y, and Z, I can guarantee you won't get Alzheimer's disease. What everyone can say and should say free of charge is everyone can take these steps to try to lower their risk. And I think the evidence is extremely compelling for not only that getting enough fish in your diet is good for your brain, but that not getting enough fish in your diet is dangerous for your brain. And so eating fish once a week is a really good idea. And if you can't eat fish, if you have some sort of allergy, then you should talk to your doctor about supplementation for some of the essential things in fish that may be vital to brain health. But again, the studies of the supplements have not been as convincing as the studies of dietary patterns of eating fish and other healthy foods. After fish, I do think that avoiding those foods high in fat and cholesterol, making sure you're getting a lot of those other sources of healthy fats, the polyunsaturated fats in the form of olive oil and mixed nuts. There's really some pretty amazing evidence for adherence to the Mediterranean diet or the Mind diet. There are variations. And there are ongoing prevention trials to test whether we can actually move the needle on the number of people who get Alzheimer's disease and dementia by randomizing people to these diets or a low-fat control diet in some cases. So stay tuned, more to come, but make sure you're getting fish and otherwise eating a pretty healthy diet.
So our next question, we got three, it all have 3 votes right now. So I think since the second one kind of ties with what we just said, are there any kind of known causes that contribute to Alzheimer's outside of just diet? I mean, I know you mentioned smoking and things like that.
Yeah, I mean, smoking doesn't cause Alzheimer's disease. It probably changes the brain's milieu and makes it a more permissible environment for the wrong things to happen in Alzheimer's disease to occur. But, smoking is just not good for any organ in your body, including the brain. We get a lot of questions about other potential causal factors, be it aluminum in the water or cooking with aluminum pots. I love to tell the story that many years ago was in Oprah's magazine. I was asked to comment about whether aluminum in deodorant could cause Alzheimer's disease. There's a long and checkered history in science about aluminum and Alzheimer's disease. Basically, there were some scientists who were studying seizures in the brain, and they were causing seizures in an animal model by injecting aluminum salts. And when they looked at the brain of animals that they had caused seizures, they thought they saw neurofibrillary tangles like what happened in Alzheimer's disease. They were incorrect. They weren't actually neurofibrillary tangles, but by then the damage had been done. Some hasty studies of drinking water were performed that misconcluded a relationship between the amount of aluminum in the water and the rates of Alzheimer's disease in geographic areas. And word was out, and it's been extremely difficult for the field to dispel this myth. Aluminum is not a cause of Alzheimer's disease. You can keep using your cookware, you can keep drinking your water. You shouldn't eat your cookware or your deodorant, but other than that, there's really not a relationship with Alzheimer's disease. There are other lifestyle risk factors that are currently under study, and there are some intriguing ones like air pollution and potential relationships between the amount of air pollution and the frequency of Alzheimer's disease. That's been shown in multiple studies now. These are small relationships, but they do seem to change the total risk. And again, if you live in an area with a lot of air pollution, it doesn't mean you're going to get Alzheimer's disease. There's no geographic area where everyone gets Alzheimer's disease, just like there's no geographic area where no one gets Alzheimer's disease, except perhaps areas where people don't live long enough. What it means is that if you find yourself in an area where there's these risk factors that are out of your control, it may be all the more important to take steps towards reducing risk factors that are in your control.
So then next question is there an average age range that people begin to suffer the effects of Alzheimer's?
Yeah, so this is a late life disease. So I mentioned that the risk of getting Alzheimer's disease begins to go up exponentially at age 65. There are really important studies of people who are younger than that, and indeed the cases of people with Alzheimer's disease where the age of onset is in the 50s or in the 50s, for example, is quite difficult. But still, the greatest number of cases is going to be in people over age 75. I think you muted, Chad.
I am. So similar question then is, what's the average lifespan for someone that's been diagnosed with Alzheimer's?
Yeah, there's variability in how long a person lives with Alzheimer's disease, and the older you are, the shorter the lifespan. Alternatively, the younger you are, there's some indication that the disease may be more rapidly progressive. But we generally talk in big kind of general numbers as 8 to 10 years that a person lives after diagnosis through death. And I should have said, this is a fatal disease. This is the 6th leading cause of death in the United States, will be 7th because of COVID, but it'll come back to 6th and is increasing. And it's the only cause of death where we don't really have a treatment to prevent or cure it. So it's really a big deal. People with this disease will have a deteriorating progression. They're going to get worse over time. The rate at which they get worse may vary from person to person, but it's kind of inescapable that people are going to get worse. And ultimately, most patients, unfortunately, end up completely dependent on others for their even most basic activities of daily life, feeding and toileting. Many patients end up in skilled nursing facilities. And they may succumb to things like pneumonia, or in particular aspiration pneumonia, because the swallowing mechanism is controlled by a part of the brain that ultimately will be degenerated by the disease. But even though pneumonia is the immediate cause of death, they wouldn't have had pneumonia if they hadn't been bedridden and their brain under attack by Alzheimer's disease.
So then you think along those lines, then have you seen, or is there any research that Alzheimer's is more prevalent in male versus female?
Yeah, there's a lot, including here at UCI Mind. And women get Alzheimer's disease much more than do men. So about 2/3 of cases of Alzheimer's disease are female, compared to 1/3 who are male. The biggest driver of that is that women are better at living to the ages when the risk for Alzheimer's disease goes up exponentially. But it is clear that that is not the whole story. And there's some really interesting findings about whether the risk genes may work differently in women compared to men. Here at UCI, we've got a partnership with Maria Shriver's Women's Alzheimer's Movement and something called the UCI Mind WAM, Women's Alzheimer's Movement, Women's Initiative. And we've funded about $500,000 in projects, 5 different projects here at UCI, to try to study what is causing the differential risk in women compared to men. And some really interesting findings so far, but none yet that we can immediately translate into recommendations for folks or clinical practice.
Got it. So the next one, this could be a fun one. So I'd say definitely be general because it could get political. But if Alzheimer's is such a growing problem here, why aren't there more Medicare funds being allocated for home care instead of sending someone into SNF?
Yeah, I mean, why are we as a society not devoting more resources to helping families with Alzheimer's disease? It's a really fair question. You can target Medicare, or you can target other aspects of our healthcare system. I think that we are coming as a nation, as a global society, to an important realization that this is a big deal that we have to do something about. When I began my career as an Alzheimer's disease researcher at around 2007, Every grant that I submitted, I had a less than 1 in 10 chance of getting funded. Thankfully, through tireless efforts of advocates, we've seen a quadrupling of the NIH budget to fund research toward Alzheimer's disease. Is that high enough? No. Is it still dwarfed by some other indications like cancer? Yes. But, it's certainly a major, major improvement. And there is a lot of really fantastic work that's happening now in the research space because of those efforts to increase the NIH budget. Should we be making similar pushes for greater spending to support families, more resources? Absolutely. And, I'm here in Irvine, California, in Orange County, California. It's a resource-rich environment, and families still need more, even though there are more things here than in a lot of other parts of the country where families are on their own. And this is a tough hand to be dealt, no matter where you are or how many resources you have available to you. So, yeah, I think we can all advocate for a lot of different things that would help families and for resources to try to find ways to stop this from happening altogether.
So then, along those lines, then too, are there different grades of Alzheimer's? So, like an example, a diagnosed family member around age 90, they can remember the past, but not necessarily yesterday or even this morning. They can carry in conversation and may or may not remember it, an hour later. And
Yeah.
Is that just normal old age, or?
Yeah, so the brain does age independent of brain disease, and so we can't expect our memory performance, our cognitive skills to change a little bit as we age. Things that numbers we used to add up in our head, we might grab a scrap piece of paper and jot them down. That's pretty different from what I would refer to as the pathological signs of a brain disease. So, not remembering where you put your keys every once in a while, that's pretty normal. I come out in the parking lot many nights and go, uh-oh, where did I park my car today? But that's different from the memory function impairment that comes with Alzheimer's disease. In Alzheimer's disease, the part of the brain that is involved in putting in new memories is typically the first affected. And so we see what we call short-term memory impairments in patients with Alzheimer's disease as a first presenting symptom. And it's pretty easy to distinguish from those normal changes in memory, forgetting where you put your keys and things like that. This is going to be asking the same question over and over again in a conversation, because the person just doesn't have the ability to put that memory in that they asked that question already and got an answer. So repetition, challenges in spatial navigation, getting lost on the way to a grocery store you've been shopping at for 10 or 20 years. Those are big warning signs, and they're quite different from a normal aging process. And then to get at the grades, again, I said this already, but the disease is going to get worse over time. And so eventually other domains of cognition are going to become involved. The functional losses associated with these cognitive problems are going to get greater and greater. So it may start as an inability to work your iPad or plan a party, something that is higher in function, but ultimately it's going to grow and increase to include other more typical daily functions that are much more problematic for the person and the family when they become impaired. And as far as stages of the disease, people do like to try to put stages on the disease, and many people come to me and say, my mom's in stage Q, and I don't necessarily know what they are referring to when they say that. There are good staging systems that have been developed for a reason, but the ones that I typically refer to are the ones used by the FDA, because a big part of my job is trying to develop new treatments, and those are typically mild, moderate, and severe dementia. We do have a diagnostic category of mild cognitive impairment. And indeed, the new drug that was approved in June is approved for people with MCI or early mild dementia. And MCI means that someone has memory problems or other thinking problems that we can detect with standardized tests, but that they don't get in the way of living life. They're functionally intact, but they're at great risk for developing dementia over the next couple of years. And if the brain scans show us that plaques and tangles are present and are the cause of those memory problems, the risk of moving on to dementia in the next couple of years is very high.
So, I mean, just because I think it ties perfectly to that is, so what are the kind of first signs that you would see of Alzheimer's?
Yeah, I mean, classically, we talk about memory problems and spatial navigation problems like I described before. But increasingly, we recognize that does not have to be the case. People can have language impairment that can be in the production of language or the ability to interpret language. People can have decision-making problems. There are some horrific examples of people who the first presenting symptom became, poor decisions around finances, being taken advantage of by scams, making mistakes on bills, not paying bills. And that can lead to great financial challenges for families who are afflicted with this disease. And then, we've got some great work happening here about the possibility that behavioral symptoms are the first presenting sign of Alzheimer's disease. Now, I didn't really talk about these yet, but they are among the most challenging symptoms that can happen in Alzheimer's disease, and they happen in essentially everyone who gets the disease. We think of some of them as being more tied to late stages of disease, like delusions, hallucinations, aggressive behaviors, and they often are the straw that breaks the proverbial camel's back and cause placement in a skilled nursing facility or a nursing home. But early in the disease, depression, apathy, anxiety, these may be more prominent. And there's a lot of important work happening about geriatric depression and whether it's just the first sign of Alzheimer's disease. So a lot of work left to be done, but those behavioral symptoms, in at least some cases, are the first sign of Alzheimer's.
Got it. So then the next one, because I know it sounds like some people are just now curious and they might want to get tested themselves. Do you know by chance, are you able to get a CAT scan if you have a pacemaker?
So CAT scans are not super valuable for diagnosing Alzheimer's disease. We think of MRI as more valuable, but PET scan is what I was talking about as those things that show us the plaques and the tangles. And depends on the pacemaker as to whether or not you can have the scans with a pacemaker. So you'd really want to talk to a doctor about that. And, as far as identifying people who are at greatest risk for these things, we still don't recommend the scans for people who have normal memory, except in the setting of participating in a research study. We have a lot of things we still don't yet know. Not everyone who has plaques and tangles present in their brain will someday get Alzheimer's disease, and we can't tell who will and won't, although we know the risk is much higher in all those people compared to people who don't have the plaques and tangles. For the people who will, we don't know when. What if it's not for 20 years? Do you really need that information now? Again, if you're already in your 70s or 80s, are you worried about getting Alzheimer's disease in your late 90s or hundreds? That's a question only you can answer. So right now, we don't use those scans in clinical practice for people who don't have cognitive problems. This will eventually change when we have treatments that can successfully delay the onset of the disease. And there's some really exciting work in blood tests, and blood tests may be able to give us just about as good of information as the scans, because right now the scans are quite expensive. They cost in the thousands of dollars, and they're not covered by insurance either. But maybe cheaper blood tests will let us do things in much larger scale when the time comes.
I want to pull the next couple from the chat box real quick. Has your research seen any correlations with positive brain function and intermittent fasting?
There's not, to my knowledge, great data about intermittent fasting. I actually, later today, I have a meeting of a data safety monitoring board for a dietary study for people with Alzheimer's disease. So I think that diet is an important thing to continue studying, and there's a lot of different things that have value. Some people have studied the ketogenic diet because ketone bodies are an alternative source of energy for the brain. Jury's still out. I haven't seen a lot of studies about intermittent fasting, which would be, things like taking a day off from eating once or twice a week. The other thing that's kind of exciting in the field is time-restricted eating. Can we eat the normal amount of calories, but consume them in a very finite amount of time, and have longer periods of fasting between meals? So that's time-restricted eating. Again, not a lot of clinical work, some animal work that's exciting, but a lot of studies that still need to be done to make any sort of recommendation about not just Alzheimer's disease, but really, what does it do to brain health overall at all?
Yep. And so the next one, and you talked a lot about just kind of exercise, but can you kind of speak to, again, the correlation between exercise and cognitive functions? I think this participant's understanding is that UCLA and the MPTF did a pretty big long-term study a while back.
I mean, there have been lots of great studies at lots of great places. I used to work at UCLA. I can't place what MPTF is, but there have been studies of exercise that do show great correlations between the amount of exercise we get and brain health. Various ways that we can measure that. It might be cognitive performance. There have been studies that suggested people who get more exercise have less plaques and tangles in their brain even. Right now, I can't tell you the recipe. I don't know the exercise dose. That is the magic number to make sure you don't get Alzheimer's disease. And I don't actually believe there is one. I've had far too many people who did everything exactly right, were exercisers, ate a healthy diet, and still got this disease. I think probably what we're talking about is gaining years. And why wouldn't we do that? If we can gain years of our life with normal memory before Alzheimer's disease begins, if we're destined to get it, we should all do that. And again, I guess I didn't say this. If we had a drug that could delay Alzheimer's disease by 5 years in everyone, we would cut the total number of cases in half. There are some benefits to studying an end-of-life disease. And a drug that could delay dementia by 10 years would essentially eradicate Alzheimer's disease. So we should all do everything we can to gain those high-functioning years, just in case we might be destined to get Alzheimer's.
So the next one, this gets to somebody's family member, age 65, excellent health, has frontotemporal dementia. Do you happen to know if this is treatable? Like, what's the prognosis, and is it likely to lead to Alzheimer's?
Yeah, so I didn't really get into the other causes of dementia besides the reversible ones and Alzheimer's disease. But Alzheimer's disease is clearly not the only neurodegenerative disease that results in dementia. There are a variety of other conditions that are far less common, but frontotemporal dementia is, I've seen studies that refer to it as perhaps the most common early onset cause of dementia. So frontotemporal dementia is a different degenerative disease of the brain. It affects the front parts of the brain, sometimes just on one hemisphere of the brain. And it does have an age of onset that's often in the 50s and early 60s. The presentation of the disease is often strikingly different. These patients will present with personality changes, decision-making errors, an inability to inhibit basic desires. So they'll experience changes in their eating habits, eating a lot more sweets. They may gain weight as a product of that. They may become hypersexual and less, more disinhibited, talking to strangers, eating food off of a stranger's plate at a restaurant, things that, you just wouldn't expect of those folks when they were not sick. So it's clearly a brain disease and a very challenging one. There is a lot of great work. We've got one local expert here on frontotemporal disease. I think, the world's mecca for frontotemporal disease study is UCSF, UC San Francisco, where they have done a number of really valuable clinical trials. Nothing has hit yet. We don't really have good treatments for frontotemporal dementia as yet, although some non-pharmacologic therapies, especially if it presents with a main language component, speech therapy can be helpful. But there's a lot of really important work ongoing. And, these patients, it's not quite the same, but these patients also get tangles in their brain. Again, but more in the frontal regions of the brain, sometimes on one hemisphere. And we don't yet know if we can develop anti-tau therapies. Could they work in Alzheimer's as well as in frontotemporal dementia? We just don't know the answer to that yet. But of course, we hope that we could find something that works for everyone.
Yep. So the next one we had is, do you know of any links between plaque on the brain and brain strokes?
Yeah, so plaque, amyloid plaques or neuritic plaques accumulate in the brain of a person with Alzheimer's disease. It's composed of a protein called beta amyloid. That protein in plaques, the beta amyloid protein, is in between brain cells and may muck up the way cells talk to each other. The beta amyloid protein can also accumulate in the walls of the blood vessel. I said that the brain is our most vascular organ. If beta amyloid accumulates in the walls of the blood vessels of the brain, it's a condition called cerebral amyloid angiopathy, or CAA. And those people are definitely at greater risk to suffer hemorrhagic strokes, lobar hemorrhages, and the like. So there's a lot of ongoing work in that regard as well. And even some interest in testing drugs like the one that got approved in June, Aducanemb, which is a monoclonal antibody against the beta amyloid protein. Now, it should not be used clinically yet to treat people who have CAA, but there are studies that are going to look at whether monoclonal antibodies that have been shown to pull amyloid out of the brain, whether they can safely pull amyloid out of the blood vessels too, and hopefully lower a person's risk for stroke if they have CAA. But that work still needs to be done.
Yep. So then, is there such thing as being too young for the disease, or any signs that that somebody's already starting to get it and they're definitely going to get worse in the future?
Yeah, I mean, the lifestyle risk factors probably start right away. Early life exposure to high quality education may lower your risk, and lack thereof may increase risk slightly. Some of the genes that we know impact risk for Alzheimer's disease, they have effects on brain function even in neonates. So we really don't know when this all starts. Is it ever too early to start adopting healthy lifestyle choices? Definitely not. Is it ever too late? Once the disease begins, these things may still be helpful. So maybe not as well. But my recommendation is always begin as soon as possible.
Yep. So the next one, this is actually, I'm combining a few questions because technically they have votes, but it's been asked a few times. Is number one, would you consider, is Lewy body considered a thing of a sign of Alzheimer's? And then we hear Alzheimer's and dementia kind of used interchangeably. That my dad died of Lewy body dementia, and it took a really long time to figure out what he had. Finally, they told us Lewy body, as the same as like Robin Williams, Ted Turner, et cetera. Do the Alzheimer's prevention efforts include other dementias, or is it kind of independent?
Yeah, so Lewy body is kind of like frontotemporal dementia. It's a different disease that can cause dementia. It's not as common as Alzheimer's disease, but it's certainly an area of intense activity in the research space. Instead of plaques and tangles, patients with Lewy body dementia have Lewy bodies accumulating, which is composed of a different protein called alpha-synuclein. These are overlapping. Actually, just this morning, we did a clinical pathological conference here at UC Irvine of a person who had plaques and tangles as well as Lewy bodies in their brain when the brain was examined at autopsy. So these are not mutually exclusive conditions. People with Lewy body will have slightly different presentation. In most cases, they'll have visual hallucinations, they'll have fluctuating cognitive performance instead of a steady decline. And they'll have movement disorder problems. So they may have tremors and shuffling gait. And there's a lot of overlap between Parkinson's disease and Lewy body disease. Basically, if a person presents with cognitive problems first and movement disorder later, they're Lewy body dementia. If a person has Parkinson's disease, the resting tremor and shuffling gait, and then develops cognitive problems, they're called Parkinson's disease dementia. But in both cases, alpha-synuclein and Lewy bodies are accumulating in the brain and attacking the brain cells. So there is a lot of energy and effort in that space as well, perhaps not quite as much as Alzheimer's disease, but the number of cases is far fewer.
This next one, I'm also going to combine because we're getting quite a few votes for it too. For someone dealing with someone else that has Alzheimer's, any resources you recommend other than some of the links we might have put in that deck? And then kind of the secondary part of that question is, do you have any tips on just interacting with loved ones who have Alzheimer's? This person says they find it hard to create a connection with their spouse's loved ones. Is it even possible?
Yeah. It is.
Hey, Josh, if you don't mind, I'd like to answer that first one real quick in terms of other resources. If you guys need help and you have a loved one that's currently dealing with this, please feel free to reach out, email me, and I can provide you with some local resources, some individuals that can maybe help you with placement if you're looking at trying to get in-home care or something like that. There are people that specialize in that can help you through the process. I myself have used someone here locally. My mother-in-law is 64, and she's already in a skilled nursing facility with early onset dementia. So this is something very near and dear to me. I will give you guys an email to use at the end of the webinar, and then you can reach out and I'd be happy to provide some resources to you.
That's great. I'll echo what you said. I mean, there are resources out there and you have to look for them. You have to find them. You have to try to take advantage of them. And sometimes it's really hard for especially single caregivers who don't have a lot of family support to even take advantage of the resources that are out there because they can't imagine how they're going to fit that in to the daily routine of providing care. There are some good books out there. People like the 36-hour day. There are some educational programs that are out there. One called Savvy Caregiver that a colleague from Emory actually developed and has been kind of gone national. There was a study ongoing of even doing a Savvy Caregiver so that people who couldn't go take the classes in person could do it online. So you have to look for what's out there. Definitely reach out to Paul and see what his experiences are and talk to other people. I mean, support groups are hugely valuable. And we've got some folks who are close to us who've started novel support groups. There are numerous organizations that host support groups. Learning from others' experiences and what did and did not work for them. It doesn't mean it'll work or not work for you, but trial and error is ultimately important. And to get to the second part, I think it's really important to remember that this is still your loved one. This is still a person who is a human. This is part of the ethics of this disease. Obviously, the organ of personhood, the thing that makes us uniquely human, is under attack, but they have an illness, and they are still the person you love, and they need your care. It's a very hard disease, but maintaining their dignity through the course of this disease is extremely important for us to think about doing. And then lastly, for everyone in the audience, help out caregivers. This is tough. There are at least 15 million Americans who are providing care to a loved one with these diseases, the various forms of dementia. And it is a tough, tough, tough spot to be in. I'm sure most of our audience has, faced this disease in some manner or another. But Paul can tell you, I can tell you, many people on the call, I'm sure, can tell you what this does to families. It's an incredible burden. And I'm sure that people who are providing care to a loved one with Alzheimer's disease would benefit and be incredibly grateful for even the smallest gesture of support that you can provide them.
Great answer. So then next question is there any kind of research, this goes back to, I think, the male versus female connection between estrogen and Alzheimer's, thinking about the differential risk?
Yeah, so, there are a lot of interesting studies about, what happens at menopause. Does it explain the difference in risk between women and men? Even some studies that suggested perhaps differential rates of dementia between women who do and don't replace hormones. That led to some large clinical trials, randomizing women to hormone replacement and several variations of those trials, to be quite honest, in which hormones were or were not replaced. And I would say they've been equivocal at best. There's still debate about this very topic. And even some of the studies suggested that maybe replacing hormones could increase risk for dementia a little bit. So that's why I say equivocal. Ultimately, this boils down to talking to your doctor, who's going to help you make decisions about hormone replacement at menopause, and making the best decision for you, considering all the various things that you might be concerned about, because there's been studies like that about dementia as well as cancer risk. And it's a very mixed literature that I think it's fair to say there's no real consensus as yet.
So then next one I'm going to pull actually back from the chat box because it came in quite a while ago, is DHEA sulfate levels. Any correlation to prolonged levels in Alzheimer's? It might be a little specific.
Yeah, it's a little specific, and I admit I'd have to dig in the literature to feel confident answering that one. I I will agree to do that for Kathy if she'd like me to.
And so then I think the next one's a similar line. So you might not be able to answer all of it being specific, but especially the last part. But do you have any thoughts on some of these like recent therapies? Biogen has one. What about Eli Lilly's therapy?
Yeah.
Do you think it's going to get FDA approval? The biggest one there is, are we making progress on medical device or advances in the space?
Yeah, I mean, we're definitely making progress. And I did talk about Biogen's drug. I don't know that I said Biogen while I was doing it, but Aducanemb is a drug that Biogen developed. And I can say that I was an investigator in the phase 1 study when I was at UCLA, and we were a site for the phase 3 studies here at UCI. And this is a milestone. The FDA has approved that drug. They did so on June 7th, again, through this accelerated pathway, because the evidence for a clinical benefit of Aducanemb is just not quite there yet. And I've been, I wouldn't say I've been vocal, but I've been public in my stance that I didn't think the evidentiary status for FDA approval had been met. And the accelerated pathway uses something called a surrogate outcome. So instead of a clinical benefit, the FDA said, well, we know the drug lowers amyloid in the brain, so we're going to approve it based on that. And I agree that the drug lowers amyloid in the brain. I'm just not sure that that tells us that there is certain to be a clinical benefit. I think, tangles might be a better surrogate, but even there, we don't know for sure that a drug that lowers tangles or stops the spread of tangles will have a clinical benefit. If the drug has a benefit, it's a relatively small benefit. People with early Alzheimer's, dementia, MCI, they may progress a bit more slowly when they're taking Aducanemb than if they weren't taking a drug. It's not convincingly been shown yet, but it may be true. And I think it probably is true for at least some people. We're not sure who, we're not sure what the best case scenario is. But I can say that the question alluded to some other drugs from Eli Lilly. They have a drug called donanemab. There's another drug from Eisai called lecanemab. Those companies have submitted for the same FDA approval through the accelerated pathway. And for all these drugs, we do think that the benefit could potentially be greatest when treatment is longest in duration and started as early as possible. And that's where those prevention clinical trials really come in. If the effect is relatively small, but you start years before the onset of memory problems, that could be a really a game changer. And that's where we might see not only individual benefit, but a public health impact of these types of treatments. Those are studies we have to do. Those are studies we are doing now. The AHEAD study that I mentioned is testing lecanemab. I believe that Eli Lilly has already announced that they will do a prevention clinical trial of donanemab. And we'll wait and see if Biogen will make similar announcements. I'm not aware that they were going to at one point, and I'm not sure where they're at right now. I think you might have muted again, Chad.
So I'm trying to mute while I type. So I really have about 15 minutes left, so I'll try to get through some of these quick. I think the next one in here is getting a few votes is it recommended that those with progressing Alzheimer's stay in the home or better to move them to a mental care facility to maintain high quality of life? At what point do you do that? Understanding that's probably it depends type of answer.
It's definitely an it depends kind of answer. You're going to have to decide what's right for you and your family. I will say that this is a highly individual decision. Consult a lot of people, capitalize on support groups, capitalize on nonprofit organizations that have helped many, many other people come before you with this decision. I can say that some families cannot imagine putting their loved one into a facility, and I get it, I understand it. Other folks make that decision and then realize they should have done so sometime before that. So there's no exact right answer except for get the resources you need, do what you think is best for not only your loved one with the disease, but for you and your family. Caregivers, their health suffers from the stress, the burden of being in this position. So they have to take care of themselves as well.
I know for my family, when we made the choice to put my mother-in-law in there, my father-in-law was the primary caregiver. We did have home health aides, but we were so concerned about his safety and his health that got to the point where his health became too much of a concern. So that was kind of the tipping point for the family. But every family is different for sure.
Okay, so the next one, I'm going to pull a little bit down the Q&A box, because I know it's going to be quick. Would you consider salmon, quote unquote, good fish?
Salmon, yeah, salmon's a good fish. It's delightful when cooked with olive oil, with a side of a spinach salad. And we don't really know what fish is best. There's some assumption that the polyunsaturated fatty acids, DHA and EPA, are what brings the health benefit. These are, those healthy fats, but we don't really know. And the studies of those DHA and EPA as supplements have been equivocal at best. So, it may be something else in the fish or in other forms of seafood, because some studies have found that dietary consumption of seafood more broadly is associated with a protective risk reduction. So I think, eating salmon is a great choice. It is high in levels of those things that some people assume to be the essential component.
So then I think this goes back to when we're able to see if somebody has the factors that cause Alzheimer's. But I think somebody that's young, you think 21 years old, is it really the case that they can't identify if we have these factors before age 55?
Yeah, no, so there's a very small proportion of people who suffer from an extremely rare genetic form of Alzheimer's disease, where we can do a genetic test at any age. But that probably makes up less than 1% of all people who suffer from Alzheimer's disease. It is a purely inherited form of the disease, and it's a single gene mutation that you either inherit or don't inherit from a parent. You can't get that form of the disease if you didn't have a parent who had it. And if you're in a family that has that form of the disease, it should be about half of kids from a parent who carried the mutation would then inherit the mutation themselves. So it's a very unique form of the disease. It's a very important form of the disease. It's a tragic form of the disease. And the gene mutation can be tested for at any age, because you either get it or you don't. It could even theoretically be tested in utero. But again, for the other 99% of people who get Alzheimer's disease or have a family history, we can't do that test at a young age. And even the biomarker tests, the scans that I talked about, if we test too early, we're not going to pick up anything, because, we're trying to do studies now in people as young as 55. We're finding that people between 55 and 60 are rarely eligible for our trials because they just don't show the amyloid yet.
So that's an interesting one too. So I think the next one is getting into some very specific supplement. So I don't even know if you'll know it, but do you happen to know the names Prevagen? I know you mentioned there's not a lot of research around whether supplements actually work. Do you know if it improves memory?
Yeah, Prevagen, it's marketed a lot on TV. You see commercials where they claim to have identified some magical compound from jellyfish. And they also claim to have done clinical trials, and those clinical trials are not well respected in the field by people who understand how to do those studies. So I don't think we really know if Prevagen helps at all, or even if it might have side effects. I'd have to go back to the studies if I could find them. But yeah, it's to me, it's a good marketing campaign.
So then next one is, do you happen to know if chemicals in things like makeup, perfume, cologne, stuff like that, contribute to hormonal changes in Alzheimer's?
That sounds like a hard thing to study. I'm not aware of studies trying to do that. You could imagine where some of those specific chemicals could be tested in the lab to see if it affects, amyloid production or accumulation. I'm not aware of studies that have tried to do that. And as far as in human beings, it seems like a very difficult thing to try to really track in a meaningful way.
Yep. So then next one is, this goes back to exercise. We all know exercise makes us healthy. Specific to brain and Alzheimer's, is there any research around aerobics versus weights? Like, what is the best type of exercise?
Yeah, so there is a bit, but it's sparse. And what most studies have done is employed some form of exercise, or even some questionnaire about previous exercise patterns, and asked whether exercise is good for you. and good for your risk of Alzheimer's disease, and not a lot of head-to-head studies of different modalities of exercise. I would say there's a lot of great centers that are focused on this. And one of our investigators here has done tremendous work about the impact of exercise on the brain from a neurophysiological standpoint and how it's beneficial. But my colleagues at Kansas, University of Kansas, and their Alzheimer's Disease Research Center continue to produce at a very high rate studies around exercise dose, modality, specific potential benefits. There's a lot of good news there. It's not all good news. Exercise is not the perfect magic pill, but it is still something we should all do. I think aerobic exercise is the easiest thing to recommend compared to weight training, but I don't think there's a bad exercise either.
So then we said, and this is just asking an opinion again, that dementia is diagnosed when a person cannot think the same way as before. Like that seems a little subjective. So I mean, maybe I can extrapolate that out a little bit. How do you know when it is just?
So, the earlier the diagnosis, the more subjective it'll be. Typically we do perform standardized tests where we're comparing a person's performance for what we expect of someone their age and education, and we're looking at how they compare to normative values. But is this a change from the way you used to be is a very important part of a diagnosis. And if the answer is no, and if the family member says, no, this is just how they've always been, then that's probably not dementia. So, the workup, and I kind of referred to this, the scans aren't a replacement for the diagnosis. The standardized tests aren't enough for a diagnosis. It's all together with a comprehensive examination by a skilled clinician, and that's when the diagnosis gets made.
So this next one, and you might have answered this during your original comments. I've heard that someone can have the plaques and tau proteins and not be diagnosed with Alzheimer's. Can you comment?
Well, yeah, so that is true. Autopsy studies from 20 years ago told us that when a certain proportion of people in their 70s and 80s passed away, we would find plaques and tangles, even though they never had dementia. And ultimately, that was the clue that led to the imaging studies that showed us that we can find people who are still alive and have plaques and tangles in their brain and don't have dementia. And if we follow them long enough, we know they're at increased risk to someday get it. So this kind of has sparked a research diagnosis. It's not a clinically used diagnosis, but a research diagnosis that we call preclinical Alzheimer's disease. And we think that's the window of time where it may be an opportunity to try to get those plaques and tangles out once the drugs come far enough and the amyloid drugs are maybe there, and then see if that can prevent them from ever getting those memory problems. And so we need very rigorous, very difficult, very expensive studies like the AHEAD study to answer those questions.
So speaking of the AHEAD study, because I know you mentioned that, somebody did ask if they wanted to participate in that, if they have mild cognitive impairment, are they still able to?
No, so a person who has mild cognitive impairment is not eligible for the AHEAD study. The persons eligible for the AHEAD study have to have quote unquote normal cognition or unimpaired cognition. But there are other studies that are ongoing of that particular antibody, other antibodies, other promising therapies that are still looking for people with MCI or mild dementia to participate.
So next one is, so my mom is about 100, starting to show some of the symptoms of repetition. Should we be having her diagnosed? Yeah,
I mean, your mom should still be getting, so congratulations to your mom. Living to 100 is quite an achievement. It's easy to say that the data we have for people in their hundreds are relatively sparse because not that many people live to be 100 and even fewer participate in research studies. It happens to be the case that here at UC Irvine, we're home to one of the most famous studies of people in the 9th and 10th decade of life called the 90+ study. They are actually open to enrollment right now. So if you know anyone who's in their 90s or in their hundreds, I guess, or in their 110s, you might refer them to participate in that study. And you can look that study up on our website at mind.uci.edu. In particular, that study is trying very hard to recruit people who aren't white to participate, because in all of our studies, we know that Alzheimer's disease affects every race and ethnicity, but those folks who are not white are dramatically underrepresented in our studies. And we really need to understand if this happens the same in everybody. So, does the brain change at 100? Yeah, it does. Should your mom be seeing a doctor every year? Yeah, absolutely. And if there's memory problems, should that be discussed? 100%. And being in a study like the 90+ study might also be a fantastic thing to consider.
So the next one I got is, one's a little specific. So do you happen to know if some of the drugs they use for Alzheimer's patients happen to use fish oil? And then the next one right after that is, is there any research on just the use or smoking of marijuana in accelerating the disease?
Yeah. So, the fish oils have been studied as supplements and not really panned out. Eating fish is the best thing we can recommend. None of the drugs, the molecular entities that are being developed as pharmacologic therapies include fish oils as a part of them. I forgot the second part. Forgive me.
Does the use of marijuana,
marijuana
accelerate?
Yeah, so we know that people are using marijuana out there, but there's not a great evidence base to support that decision. I am part of a study that's going to be performed in the next year or so to study THC and CBD as a potential treatment for end-of-life anxiety in people, anxiety and agitation actually, end-of-life agitation in people with dementia. So, that's an important step in the right direction. I think all these things are worth studying when there's supportive hypotheses to be tested and adequate rigor to the studies, and they shouldn't just be used. But, we do exist in a different time now where the access to medical marijuana is much greater. And anecdotally, certainly, some people claim that it could help, but we need better science around that.
Yeah, we're down to 3. The next one should be pretty quick. How does FTD differ from Alzheimer's? Do you happen to know?
Yeah, so that's frontotemporal dementia, which I was addressing earlier. That's a little earlier age of onset. It's still tangles, but not plaques. The tangles might be a little different from the tangles in Alzheimer's disease. And the parts of the brain that are affected are different, and therefore the symptoms that typically present are a little different too.
And then kind of the last ones we have going on here is, do you know of any memory or any vitamins that can help stop memory loss? And then anything that can be done by children to avoid memory loss, especially if one of their parents has been diagnosed?
Yeah, so vitamins and supplements are in the same category. No good evidence for any vitamin or any supplement. And for children, all the things I said: get your exercise, eat a healthy diet, avoid the bad foods, get a good night's sleep, et cetera, et cetera.
And then, so this one's are you able to get me the link for the 90+ study so we can include it in our email blast tomorrow? So for the person that asked that link, I'm assuming there might be a few other people that want some of that. I will include that in our one email blast from BFSG tomorrow that will have, again, a link to the slides in case you want them, as well as a link to the replay for any of you that want to revisit any portion of today's discussion. And then I will include the link to the 90+ study that Josh mentioned as well. With that, we want to thank all of you for attending. We hope you found the presentation useful today. Please definitely let us know your thoughts by filling out the survey. Let us know future topics you'd like to hear about. A huge thank you to Dr. Grill for participating today, especially it's kind of 90 minutes on the spot. You're just answering questions for all of you on the line. Hopefully you found the presentation useful and informative, and we hope you all have a great day. Thanks, Josh.
Thank you, guys.
Thank you.